Okay, good morning, ladies and gentlemen. And actually, thank you for inviting me for such a nice occasion. Professor Lee, as a new leader of the Korean Society of Liver Transplantation. And the topic I assigned is minimally invasive donor hepatectomy with a difficult anatomical variation. So I really like to focus on it. And thank you for your chairperson, Koba, and Professor Joe. I have no COI. Well, actually, let me introduce a little bit about Nagasaki. Nagasaki is located at the western side of Japan. And we, apart from kidney, we can perform 4 organ transplantation, including lung, liver, and pancreas, also, and the small bowel. Last year, I hosted the Japan Society of Transplantation in Nagasaki, in which Professor Lee and other Wojtek, Polak, Porute, and Professor So kindly came to Nagasaki, and also the young members of KJTF members, Professor Choi, etc. They also came. Thank you very much. Because the location at the end of in Japan, we are the kind of portal, door to the world, even in the isolation period. So every Western culture came through Nagasaki. So we are the first medical university, Western type of university in Japan. That's why our first dean of the medical school is Dutch. And our hospital is, side by side, Dutch flag and the Japanese flag is on the roof. And we have a mixed culture, Chinese, Dutch, and onsen, Battleship Island. So please come by if you have an opportunity. So this is liver transplantation current situation in Japan. So we are little by little increasing DDLT, but we still increase the green level, which means we don't have still enough liver for the patient. Because usually if lead goes up, green can go down. But it's still, green also can go up. It means it doesn't really fulfill the needs for the transplantation. So living donor is still a lot. However, we are under the coverage of health insurance, we only allow to do the pediatric donor hepatectomy laparoscopically. So we still do the hybrid procedure in the donor of the adults. So like left side, so upper midline incision, small, and do. However, we do a lot of laparoscopic hepatectomy for the malignant disease. So we can really, get used to it and ready for the expansion of the health insurance coverage right now. So I hope 2 years from now, we can do, including robot minimally invasive donor hepatectomy. In Nagasaki, we increase the number of robot hepatectomy in the parallel to the pure or also laparoscopic hepatectomy for malignancies. And the hybrid is only for donors. However, we do a lot of robot. So this is a robotic hemihepatectomy. So I like to do the robot rather than laparoscopic major hepatectomy because the robot is kind of close to the open hepatectomy procedure. We can tie, we can stitch easily. So this is a V5 transaction, and using QSER and bipolar, we do the right side hemihepatectomy for the malignant disease. This is a right hepatic vein, so we are kind of ready to take out the liver. This for malignancy. So important point for the living donor hepatectomy is priority is donor safety and precise preoperative anatomical evaluation and key anatomical variation in the surgery regardless of MIS. So for the simulation preoperatively, we use synapse Vincent system, which is, we can do a lot of, this is the case this week. I did a hepatectomy, central bisegmentectomy for the huge adenoma. So we can be helped by such a nice, rotation. We can see every direction, including backside of the liver, which cannot be done in our bare eyes. And anyway, careful attention must be paid to anatomical variation, regardless of the approach, either MIS or conventional. So I just like to, classify the 4 parts. Artery first. As you know, in the textbook, we have such a variety of variation in the hepatic artery. Usually 50% of the regular and 10% replace the left hepatic artery from the gastric artery. And the from SMA, we have replaced the right hepatic artery, 10%, and accessory 8%, and accessory right 7%. That is usually recognized. We analyze a case of our series by Dr. Favela. She is from La Paz, Bolivia. She is an elite surgeon in Bolivia to establish liver transplantation in Bolivia. And she calculated in our data, and we have a 90% regular anatomy, 2%, the type 3, 3% type 6. So this is right hepatic artery from SMA, type 3. And type 9, this is a common hepatic artery from SMA, which should be recognized, of course, beforehand. And in the literature, even if the donor has anatomical variance, this is a DDLT, but if they have toolkits, they can do anything in the back table. So the result of the transplantation was equivalent to without the anatomical variant, but this is cadaveric. But for the living cases, we have to do a lot of, technical addition. In our facility, we always try to think about the right gastroepiploic artery if we have additional anastomosis. And even if we cannot make it for the arterial anastomosis, sometimes we can make a peripheral portal vein arterialization at the intestinal in the mesenterium. So in case of failed arterial anastomosis, we can still have this option. And the portal vein is very important. So we have such variations usually. This is called 5 minutes. Okay. Okay. So usually we have almost 90% of this anatomy, but for the right side graft, we have trifurcation, type B, type 2, and complete distant case, type 3. In our series, we have 95% of type 1, but we still have a type 2 trifurcation case like this. In this case, you have to do the plasty to make it combined in the one hole. To do this, if this is feasible to combine 2 to 1, we have to do portal venous plasty, combine it, and cut the septa, and stitch, and tie should be outside, and make it possible to do the running suture to the recipient portal vein. The recipient side, we have to adjust it. And the anastomosis could be done as one hole if the venous plasty is possible. Yes, I'd like to show my ashamed case. This is a right side graft. So this gentleman has a huge posterior portal vein. So this should be recognized. I knew that, but it was larger than expected. So I did some failure. Let me show you. So this one, I took a portal vein first, and since this is very big, I thought this is a right hepatic vein, right portal vein. So I clamped it and make sure anterior and posterior portal flow is occluded, and the demarcation line. But I found some awkward flow, but I thought this is a right portal vein. So I just proceeded and took a bioduct with surrounding tissue and started bleeding. So I emergently opened without any hesitation. It was a hybrid, so it was open, but additional, the right hypochondrium thing, and they put the left hand and elevate the liver. That is things we have to do. Then we decide to cut the bioduct first to see the whole of the anterior branch. When the bioduct is cut, you can see you can recognize anterior branch of the portal vein, which is injured, and I mistakenly injured it. So this is the whole of the anterior branch. But if the bioduct is gone, you can easily stitch it and fix it. Fortunately, in this situation, artery is not injured, so I can just proceed thereafter. But in this case, you have to open and put the left hand in and elevate the liver and cut the bioduct. Then you can do it as normal. And this anatomy is also interesting. Right side ligament teres. Probably you can sometime encounter this anatomy. In this anatomy, you have to really care about the separated portal vein. I'll show you this case. This case has a right side ligament teres. Portal vein is anterior branch is here, while posterior branch is right here. It's really separated. But fortunately, bioduct is almost normal anatomy. So this is right side ligament teres. This is a posterior portal flow. You see, this is the right side ligament teres. In this situation, country line is different, so you have to really take care of it, simulate and do it, or you can exclude as a donor candidate. But anyway, I go. So this is a anterior branch. It's really separated. In this case, you have to use a graft to make it combined, Y graft from somewhere in the recipient liver or donor, some vein from other side. This is a report from Egypt, and even if they have a anatomical variant in portal vein, they have tips to overcome it, and their survival rate is fine. And finally, bioduct. Well, bioduct is not a really urgent situation, but should be managed very well. We have a lot of anatomical variants. In our series, we have a regular anatomy for the right duct, 86%. However, we have tonification and also other things. This is Quino B. A and P is like tonification, and we have separated posterior anterior bioducts sometimes. In those situations, there's one report that they classified according to the anatomy of the bioduct. If they have a 3A, 3B anatomy like this and this, they have a more complication in the donor. So that we have to be really cautious for the donor safety and also recipient complications. We usually use, because of the hybrid technique, we still use cholangiogram to make sure where we are and where to cut. However, recently, as you do in the laparoscopic and robot, we use ICZ to identify the branches to make sure, and the quality of the ICG camera is getting better and better. So we can now really reliable on it. This is a case of the malignancy, but we can identify the right duct and cut it. Recently, in the colon field, they have a ICG contained stent, and this is a ureter inserted with stenting with ICG. It's really nice to have such a ICG contained stents, and we can identify a lot better in case of complicated anatomy. And even they developed the ICG clip to identify the lesion in the colon. So in the future, in the HPV field, we can develop it. This is one awkward case we have. This donor has a B5 branch to the cystic duct, like a Lushka. So it should be, it was recognized beforehand, so that we did a careful surgery to make this B5 alive. We did a hybrid procedure also in this patient. This is a cystic duct, and this is a B5. And we did a cholangiogram through the cystic duct to identify it's really connected to the segment 5. And it was cut for the later anastomosis and parenchymal transaction. And we did a cholangiogram again to identify its right side. This is a right duct. And finally, we anastomosis in the blue eye because it's too separated. Okay, so finally, I'd like to conclude, and thank you for listening. This is my conclusion. Anatomical variations is common and must be anticipated in the donor. And donor safety hinges on careful imaging and planning, and know the variants and plan accordingly. Thank you very much for your attention.